very briefly to Norma before Maya Serda, our manager, is going to say a few more words. The way it's going to work, people will start attending in just like in a few seconds. We'll have Norma present, and then there will be time for questions. And then, unfortunately, the room is reserved at 1, so we will want to. Okay, thank you very
So
much.
I'll finish at 5 to 1, so on.
But if there's time for questions, we'll ultimately have time for questions. So I'd like to let Maya Serda, our new manager, say a few words about Norma.
So hi everybody. So I'm a new manager at the Research Center, but I know Norma from a previous lifetime when I was a research coordinator at the center. And I wanted to come today to just say a few words because Norma has been with the Center for Research and Expertise for 18 years, and she just retired last May. So quite impressive. She was the research practitioner coordinator in charge of the leading practice of health prevention promotion and aging, and just accomplished tremendous work for the center, for the CLSC, and the NDG area, and more. So Norma, among her accomplishments, began her PhD in, I'm not sure when, but
2015.
2015, and she has completed it. She did her PhD under the supervision of Annette Liebing, who is here today at Université de Montréal, and she has come here, agreed to accept our invitation to share the results of her PhD dissertation with us. So we would like to thank you for your work and for everything you have done, and we thank you for being here. I'm excited to hear about your work.
Thank you, Maya. I'm excited to present it. This is the first time I'll be presenting the results of the research that I've done, and I'm really happy to see you all here. We have a really nice mix of people. I can see people who were involved as subjects in the research, which just thrills me that they took my invitation to come. So caregivers are here and social workers are here, colleagues, and I'm really pleased to see you all. I want to do this more informally. I don't want to make this great big formal presentation. So if you feel the need to ask a question while I'm talking, just put up your hand and we'll talk, sort of do it as we go. I was really lucky. I feel like I'm really privileged. I'm privileged to be here, but I was also privileged to be able to do this sort of work in the capacity of my job. I mean, not many people have that chance because I worked for CREGÉS for so long, I was able to fit it in even with my work responsibilities. So I want to thank CREGÉS. I want to thank this organization, the CIUS, Centre-Ouest de l'Île de Montréal. And I especially want to thank my research director, who's here today, I'm so happy, Annette, who's given me tremendous support and encouragement over the 3 years that I've been doing this. So thank you to all to be here, and special thanks to some of you as well. The research started in a sort of organic way out of my job, which was really interesting, because for many years, for almost 12 years, I ran support groups for caregivers. So doing that, I sort of got to know a lot about what some of the issues are that caregivers confront every day. The other thing is I also was lucky enough in about 2012, 2013. Sorry. Pardon me. I was really lucky to get a grant from the Research Center to start looking at issues around autonomy and loss of autonomy in older people. So doing that, we were able to start looking at some of the issues around loss of autonomy, and we realized there were some important things related to the assessment process. So when I started to build this research project, this was one of the first things we started looking at, was the assessment process, in particular the tool, the OEMC at that time, and still is in use. I'll talk a little bit about that later. So we looked at the assessment process, and I started talking to colleagues, and we started putting all the elements together that this research came to be. Oh, before that, I forgot to say, on the screen was the title of my thesis, the long title of it. So it's we're talking about expectations, because that's also the context of the research. So I'm trying to sort of weave all the issues or all the elements together, a bit like a tapestry, let's put it that way. And I'm hoping at the end, all the threads that I will weave together for you will become a sort of a nice tapestry that will be understandable. So what we have here is, first of all, what we have is the OEMC assessment process, and we have the caregivers. I decided to focus on family caregivers because that's where my experience was, and I sort of understood a little bit about what was going on there. And then we wanted to tie it all together, and we decided to focus on the idea of expectations. Because in psychology, expectations is such an interesting concept. When you think of it this way, we have expectations, and they can work in two directions. They can work in, we have expectations of others, and others have expectations of us. So we quickly realized that expectations could be a really interesting element to look at all these things that I was just talking about. So that became the research question. I'm just going to go over the introduction. So the context of the research, I'll explain it in a bit more detail in a moment. I'm going to also talk about the meaning of autonomy, because we realized that it had to be a foundation on which to build this project. And then I'm going to go over the results of the interviews. And the interviews were done with family caregivers, in individual interviews, and in the form of a large discussion group. And there was also interviews with social workers. And we're also talking about expectations in the context of always in the assessment process of elderly in loss of autonomy. Then through the interviews with the social workers, and this is how things sort of grow organically, I realized another component was coming out that was really important to social workers, and that was the organizational climate. And the organizational climate and the expectations being placed on them for assessment and different things also was a key element. So what we have in the end is the intersection of expectations between social workers of family caregivers of the system for services, and then the system, the overriding system of social workers. And I'm hoping, by the end, I hope I have tied this all in for you. So then that's what I called at the end, the intersection of expectations. So a bit more about the context. Is that, okay. So what we talk about first is problematizing loss of autonomy. Because when you look at it, why is loss of autonomy the element on which we evaluate the elderly? Why loss of autonomy? There's like a lot of other things that could have been chosen. But just to go back a little bit in history, let's say 20 years ago, it was actually a little bit more, but let's say around 20 years ago, many governments, including Quebec and around the world, realized that there are a lot of people getting older, and that this number of people getting older was going to continue to rise. And then the realizations of many systems, public healthcare systems, was that we don't necessarily have the correct tools and systems in place to meet the needs of the future aging population. So loss of autonomy was focused on as one of the principal elements of this aging population. In order to standardize the assessment and also to equalize, to make it equitable, how services are dispensed, they had to create assessment instruments. In the case of Quebec, it was the OEMC, which in English is the multi-clientele evaluation tool, which focuses primarily on loss of functional autonomy. So I won't go in. Many of you already are, the professionals here already know what that tool is. And people here who are caregivers know that at some point their relative was assessed by a social worker. So that then I'm painting the picture. I'm painting the picture of an increasing number of elderly who were going to eventually need services, and the development of assessment instruments, which became important. And they became sort of standardized across Quebec. I know, and I'm fully aware that there's a new instrument that's been created, the OXI, but I decided not to include that in here because it has not yet been fully implemented across the province, so it's not being used. But from what I hear, it's OEMC times 2. It's a continuation of, so it's not entirely different. So I'm assuming that what I've found as a result of this study would also apply to mostly to the OXI as well. So then the other part of that is we talk about the aging, the loss of autonomy, and now we're going to introduce the element of expectations for care. And this is what becomes interesting. When caregivers, family caregivers, start to enter the system via the need of their relative, they discover that there's a whole world out there that needs to be navigated that is quite mysterious a lot of times. And I think some of the caregivers here, I see them nodding. Yes, it's a whole other world that you're not aware of, that you don't know how to get the services you want. But nevertheless, there's a lot of expectations. You have the expectation because that's the way our system is designed. We have expectations for care because we live in a social health system, right? When we get old, the services will be there for us to help us out. So caregivers begin to navigate the healthcare world to get the services that they need. And at the same time, I've decided to focus on social workers, and I want to explain why. All of the healthcare professions in home care also use the same instrument. So why didn't I focus on all the professions, the nursing, the physios, and the occupational therapists? Why did I focus on social workers? The reason why was because I spoke to many of my colleagues, and I discovered through their comments that the social workers carry the clients often a lot longer. After the nursing care is finished or the physio is finished, they often get transferred to a social worker to carry them. So a lot of the social workers end up with long-term clients. And because the OEMC is so very focused on functional autonomy, that sometimes the psychosocial elements were a little more difficult to integrate. So it appeared to me that social workers were facing special challenges that were not necessarily a part of the other professions. So I chose to focus solely on social work. Also, it's good to focus in research on one particular type of category rather than to spread it out. So that's why I chose social workers. Through the interviews and through the conversations with my colleagues, informal and sometimes more formalized, a lot of the interviewees talked about the system and the way it's organized nowadays. And that has sort of evolved since the first days when we first started implementing, and then the protocols that have come in, the lean protocols, and they call it new public management and all that, has really, really affected the social worker role. And I hope to show that to you through my presentation, that the social worker role, and many studies and comments are coming out, is starting to evolve a little bit from the more humanistic one to one that's very administrative, which isn't necessarily why social workers entered the profession in the beginning. So, on the screen here you see the research question. So, the research question that we finally ended up with was, how do family caregivers, social workers, and the healthcare system's expectations influence the standardized assessment of functionality and autonomy of elderly home care clients, and how does the assessment influence expectations? I turned it around, so it's where, how does the expectations influence the assessment, and is it possible that the assessment itself influences? So anyway, the method I used was a very common and simple one. I interviewed family caregivers, and I did, as I mentioned before, a focus group, a discussion group with caregivers. I did interviews with home care social workers and an intensive, extensive documentation search. So does it make sense to all of you up till now? It's working? Okay, good. So I started to build a foundation. So the first thing that I started to do was just start, what does the word autonomy mean? And as soon as you start doing a search about autonomy, and since the assessment is based very much on autonomy and loss of autonomy, I started to look at it through the different disciplines. Because if I asked any of you, what does the word autonomy mean to you? People could say freedom, independence, empowerment, self-determination. There's a lot of synonyms we can put in for autonomy. So I started with philosophy because that's where everything starts, right? Philosophy. And so we looked at and I won't dwell on this very much because I'm not a philosopher, but if you look at the early philosophers, they talked about self-rule and self-determination, and that sort of has been indoctrinated into our Western type of thinking, that we're independent, we're free, we can do what we want because we're free, and so on. But what does that how does that relate to aging? When we're young, we want to be independent, and it makes a lot of sense. But for some reason, when we get elderly and we say we want to be independent, people look at us as, well, you're not being very cooperative. What do you mean you don't want the workers to come to the house? You're not. So autonomy starts to take on a different meaning as we're older, and philosophers maybe didn't take that into account, because in the days of early philosophers like Kant, for example, people only lived to about 50 years old, so aging was a whole different ball of wax. So then let's go toward bioethics. I found that really interesting to start looking at bioethics in terms of the concept of autonomy, because now we're talking about informed consent and our decisions to make our choices, and even to refuse care if we want to. So in the aging world, informed consent and in bioethics means a lot. However, the studies are showing that there's sort of a limit to autonomy when it comes to aging. When you have dementia, for example, do you still have informed consent? If you have not been diagnosed with dementia, you should still have the ability, but apparently that seems to fall a bit by the wayside. So that is where we still go by the doctor knows best doctrine when it comes to aging and bioethics. And of course, I had to go to social gerontology because this is my interest, and this research center is about social gerontology. And when you talk about autonomy in terms of that, now we're talking about successful aging and what they also call healthism. Now, healthism is really interesting. That's like saying to you, you have to not smoke and get your exercise every day and live a healthy life. It's almost determined that you have to live this healthy life when you become older, and you're suddenly not allowed to drink and smoke anymore. So is successful aging based on that? Going a little farther, I decided to include public policy because of the decision I made to add a chapter on how the organizational climate has affected how social workers do their job in terms of assessing older people. So when we're talking about autonomy, and we're talking in public policy, I have to admit it goes towards the social worker's ability to still make decisions without having to constantly check with their manager and get permission to have services or not have services. And there's a lot of this social worker's autonomy that is being lost, apparently, in the way the organizational system has been developed now. There's a term they call it. They're calling it the McDonaldization of social work, which is an interesting, when you think of McDonald's, what do we think of? We think of fast food and assembly lines, etc. So has social work come to that? So public policy and social work could be a whole other research project. Okay. So where are we now? I want to now talk about the family caregivers, so expectations for care. Now, you might wonder, why didn't I include the older person, the care receiver, in this as well? Initially, I had wanted to, but some challenges arose because of that. So in the end, I decided to just look at family caregivers, because the family caregivers who I talked to were able to articulate their expectations very clearly. But what was and I'll show you in a minute the results of it, the interviews. So what I looked at in this is I looked at their sources of expectations. Where did the expectations come from? I also looked at what kinds of expectations they had, and were any of them surprising. And then in the interviews, I also went back to the concept of loss of autonomy and what it means to family social workers. And I think you'll be a little interested and surprised about what some of them said. So in terms of the sources, the source of expectations can come from inside ourselves, and they can come from the outside. In the case of the people I interviewed, it appears that the expectations come from often from what other people have told them. Like, for example, your neighbor or your sister or your cousin in the next town has said, oh, well, when I needed care, this is what I got. Or they could come from past experience. For example, you may have cared for a family relative 10 or 15 years ago, and the system worked in such a way at that time, and you got certain expectations, you had certain services and care. So it's understandable that a caregiver of today would base their expectations a bit on their past experience. Without realizing, and this is where we come into that mysterious navigating of an unknown system, is that the expectations are based upon a system that doesn't exist anymore. That the way it's organized is not the same as it was 15 or 20 years ago. So if your knowledge of what you expect to get is based on that, it's probably no longer relevant. There are other places where we get expectations. We get them from the news. We have these wonderful advertisements saying the healthcare system is there for you. It's on the internet. You go on the internet, which I did, and it's, well, if you call your CLSC, this is what you can expect to receive. The other place where people, the caregivers especially get expectations, develop expectations for care from the CLSC, is from what they are told by other health professionals. And what I mean by that is, if you have a relative in the hospital and they're about to be released, someone from the hospital usually tells you, okay, I'm referring your file to the CLSC, and someone's going to call you, and you could expect to get some home care services. Unfortunately, there is sometimes not a great communication, so what you were told at the hospital and what you discover is available at the CLSC could be totally different. So the other thing that I discovered also creates expectations is just the assessment process itself. And that means if someone calls you and says, I'm coming over in a couple of days in the afternoon, makes an appointment to assess, and we're going to see what your needs are for care and services. I think it's really, really understandable for someone to say, now I have expectations because someone is coming to evaluate. So all of this works together. So right from the get-go, there are expectations. So what are they? The research, the analysis of the interviews showed me that there were 5 areas that stood out in terms of expectations. Surprisingly, many of the caregivers I interviewed said initially they had none. They felt they didn't know what to expect. They were just wide open. However, later on through the interview, it appeared there were expectations. It's just they weren't necessarily aware of what they were. The category, what I called to be treated as an expert. Now, many caregivers are very knowledgeable. First of all, they're very knowledgeable about the illness of the person they're caring for. They're knowledgeable about the what the needs are and what they need, what sort of help they need, and they want to be treated as the expert. And I put expert in parentheses just because no caregiver said that to me. No caregiver used the word, I want to be an expert. That was the interpretation I put on it. For example, if a caregiver says, I have the power of attorney, I pay my taxes, what happens should be my decision. But the services that are available, at what they come to realize, are not on demand. You can't say, I need this, and I need this, and it'll all automatically be received. This is when they discover, this is in terms of navigating the mysterious healthcare system, that a lot of the decisions of what they're going to get or not are based on a long assessment form, which I'm going to explain a little bit later, which actually can contribute to a disappointment as well, because the assessment form, which intends to evaluate a person in a neutral way, sometimes overlooks some of the things that should be there. Caregivers nevertheless want to have information. They want to have information about resources and where they can get more help. And usually they get that. That's usually an expectation that's satisfied. The social workers are very, very good about supplying the information that they need. Now, I don't think it's surprising for you to know that one of the things that they want is care at home. They want help they don't realize that what used to be offered, which is in terms of shopping and cooking, those don't exist anymore. But they are offered often some respite, provided the budget is still there to offer it. And they are offered bathing and some help with dressing. The services exist. It's all based on this evaluation form that they don't necessarily always get. Caregivers also want support for themselves. Now, what I found in interviews, the boundary between support for the relative and support for themselves is blurred. So sometimes they perceive support for the relative as support for themselves. And this is the other big learning curve of caregivers. They realize that they are not clients. They are not clients of the system. They are the caregiver. Although in many of the interviews, the caregivers express the need as if their need and the need of their care receiver were one of the same. The other big thing that came out in the interviews was some caregivers think they want placement for the relative. They think it's time. They're at their limit. And they believe that the steps should be put into place for their relative to go into long-term care. And then they discovered that it's not their decision. And that's another surprise to many of the caregivers that I interviewed, that it wasn't their decision. And also, by the same token, several caregivers were also surprised that the decision was taken out of their hands, that it wasn't their decision, that a crisis had happened, and they were told by social workers and hospital workers that you cannot do this anymore. And this sometimes created some resentment. So that's a summary of the expectations that stood out. I'd like to also talk to you about, in terms of the interviews, what the meaning of loss of autonomy is for caregivers. Now, loss of autonomy, and I have to admit, I went in with a preconception myself. The loss of autonomy is being experienced by the older person who is ill, right? This is loss. And then I discovered in the interviews, it has a mirror effect, or I called it a rebound effect, on the caregivers who also perceive themselves as in loss of their own freedom and autonomy, because now we're going back to freedom and autonomy. Our decision-making process, this is going back again to the informed consent in bioethics, informed consent in bioethics. So there's very unclear boundaries between how they can make the decisions they want to make. I put up a couple of quotes that really struck me in the interviews. Loss of autonomy means loneliness. This is a caregiver talking about themselves and making the decisions. Before, you were making the decisions with your husbands, and now you have to make the decisions yourself. It's like saying I'm a widow with a husband. What's worse, a widow without a husband or a widow with a husband? It's sad. And I don't think we always realize the rebound effect of the loss of autonomy of the elderly person on the family caregivers. Now I'm going to go on to the social workers. So in the social workers interviews, I focused on questions about what do they think about the instrument itself, the OEMC, and I've included the psychosocial assessment, which many comments were made by social workers. Also, their types of expectations of caregivers and the expectations of the system on themselves. Of the instrument itself, of the OEMC, in general, social workers had a positive opinion of it. Many said it's a good tool, but it's a snapshot. It shows the status of the person on that day and time of the interview, and it's not really a portrait of how they are every day. It's how they are at their worst, one of them said. The resulting score, now I didn't explain this, but the OEMC produces a score, which often is a determinant of services. So sometimes the score, they know, is not consistent with the client's reality. So as one said, the score is important too, and maybe it's too important. You really want it to be reflected of the client's reality because it influences your ability to get services, and it influences your ability to get into residential care. So there's a lot riding on that number. What really came out, though, that in the interviews was, although there's questions about the caregiver, there's not a place to really assess the caregiver. Their willingness, there's just an assumption that the presence of the caregiver implies a willingness to provide the care. Sometimes the caregiver is present at the assessment but may have no skills or even desire to be a caregiver, but that's not necessarily a formal part of the assessment. That was one of the recommendations that was made for improvement of the assessment process, a more formalized process of the assessment of the family caregiver who would be there, or even other family caregivers in the picture. Social workers' expectations of caregivers, they expect caregivers to be reporters because they're their eyes and ears on the ground, and because the family has more of a view of the situation than I do, and to keep them in the loop. They want them to be information givers, but not to talk too much. They have a tendency of speaking for, but they're a wealth of information. And I'm going to explain that in a minute. They would expect the caregiver to be a resource. The presence of the caregiver assumes that they are a willing resource. I think right now when the worker goes to do an evaluation, I think they look at the caregiver as a resource, one said, but they're also compensators. And that's a big role of caregivers. And they are coerced, so one said. They're coerced to a certain degree into being the compensator. And at the cost of their own health and at the cost of their financial well-being and their personal development. What I found so interesting about the interviews with the social workers is they're very aware of the fact that the caregivers are being pushed to their limit, and they have no means always to help them out. And then they expect the caregivers to be help seekers on their own right until they start asking for too much. And unfortunately, as one said, sometimes they have higher demands than the client, but also it could be because the caregiver is more articulate than the client. And they're the ones compensating, and then they're not our first priority. So one of the first things social workers have to do is explain, to demystify expectations right from the very beginning. You're there, but you're not our first priority. Our first priority is the client, and really that's where our stats are coming from, which is not actually said to the caregivers. Time is running, so I'm going a little faster. Organizational expectations of social workers. This came through loud and clear. The organizational climate is having an effect on the social workers and the other professions too, but since my focus was social workers, this is where I stayed. There's budget control, there's waiting lists. Social workers are in the untenable position very often of trying to balance the expectations that are placed on them and the expectations of the caregiver and what they expect the caregiver to provide as well. They're doing this juggling act of they have to stay within the protocols of the organization because that's the way the system is set up, and satisfy the client because there's a vulnerable person in front of them. So I called it the 3 Ps. They're expected to be productive. As one said, I think it's all about the numbers. Sometimes I wish I had been more around the table when they kind of decide on, say, more visits. They wanted, their performance was the 2nd P, so they have to do case management and supervision, statistics, definitely, and they have to show leadership. And also in terms of professionalism, they have to respect the rules of ethics and confidentiality and judgment and training. So there's a lot of expectations, as I said before, on social workers, and in terms of the McDonald'sization, feeling that their humanistic role as social workers is being a little bit diluted. So I kept this quote. It's a bit long, but it says a lot. Don't get me wrong. I wish I could just do 7 hours of seeing clients. That's what I was trained to do. I was trained to do clinical work, to meet clients and help them resolve their issues, to help them advocate. But there's that big beast that needs to be fed, and that's the system. That's charting. There's a need to produce stats. In filling out reports, the stats and number of home visits. Well, you can't do 10 home visits a week and do all the charting. It's impossible. It's achievable in the short run, but it's not maintainable. That comment sort of capsulized the sentiment of many of the social workers that I interviewed. So it sort of creates a system that's very difficult to work in for them. So I was interested thinking, well, okay, I did the social work interviews at a certain point of time. Has anything changed since then? Because about 1.5 years had gone by. So I recently did a few follow-ups and asked them, okay, what about the new social workers coming into the system? Is it still this, how are they managing this system? And I retained one particular quote from those. New arrival social workers seem to be overwhelmed by the complexity of the system. The grind is tough and it's hard to maintain. They go on the treadmill and it's hard to keep up with the demand. The new OXY, which is the new instrument that I mentioned earlier, the extension of the OEMC, is longer. It's going to involve more paperwork, more numbers, and more stats. That's not a very positive picture. So I would say that could be something to take into consideration when you're trying to recruit new social workers. So the second to last screen is what I call I don't know if you'll be able to read that very well. It's kind of small. But what I call this is the intersection, because this is actually what I was aiming for, is to look at how they're intersected. The first column on the left talks about the organizational expectations according to the protocols that have been produced by the government. The middle column are the social workers' expectations of caregivers, to which I've drawn lines to the family caregivers' expectations. Now, the expectation of the social worker in general is that the caregiver is a giver of care, and the caregiver's expectation is that they are receivers of care, which is a nuance, but it's an interesting one. So I drew lines connecting their expectations with the social workers, but what I want to highlight in this is what could be called a clientization process, because the way the system is designed as it is right now, with the demands that are placed on social workers and the formalized interviews and the evaluations, the caregivers are becoming what we call clientized. And it's a whole process where they say, in order to get attention, my troubles that I have, which is the family caregiver's troubles, need to become problems. I need to become a problem for the social worker to get the attention that I need. So it's almost like the system itself is set up to be for the caregivers to become problematized to get services and care, which isn't what the intention is. Absolutely not. Nobody wants the caregivers to burn out, but several of the social workers said we're very aware that what we're asking of them is burning them out and making them become clients.
But I'm thinking there's also probably the risk of burnout in social workers too.
Yeah.
Always working with caregivers who are burning out because of the constraints.
Well, I didn't go into that, but there's, they talk about the higher attrition rates and there's a lot of staff turnover and absenteeism and all that. But I didn't include that because I didn't want to make the thesis totally on managerial protocols. But yeah, it is a reality in the system right now of certain amount of staff turnover. So in conclusion, Sybil, 2 minutes. Okay, I'll conclude in 2 minutes. So going back to the idea of deficits-based assessments, is that the right way to go? Is there other ways that we can assess in a more humanistic way? Social workers also have another form that they are supposed to complete, a psychosocial assessment, which they feel is not always respected. But for social workers, this might be more relevant. If the system is actually creating a clientization process in which people who, with a little more support and a little more services, don't turn into clients, could that be the development? Could that be what we're looking for? The implications for practice, I tried to imagine what they could be. I'm hoping maybe some social workers here could give me some ideas of what implications for practice. I see it as sensitization, but mostly I see it as if you have a raised awareness that the person you're meeting and the caregiver have many expectations. Like, for example, some social workers told me that the first thing they did was demystify the expectations so they would avoid the disappointment of telling them that they can't get what they wanted. So maybe there should be a more formalized process in that as well. One social worker told me that he had created actually a form of his own that he uses himself. And so perhaps that's the idea. So I think I'm within my time, and I welcome any questions or comments from the floor. And the internet. Apparently there's 20 people observing from outside. Okay. Annette?
Yeah, I have three very small comments. The first is that I'm so proud of Norma. Really, she comes from, really. Norma comes from practice, so she's not a typical academic, but really learned how to do interviews, and she was not only a description, it was really an analysis, as you could see. So I think this is really fabulous work. The second comment, and I think Norma didn't have time to go into, for me the most amazing finding was actually this immense process of measuring loss of autonomy, which takes a long time and all the paperwork around, and then you get a profile or a score, and let's say she needs this and this and this and this, but then at the end the system can't offer it. So this big gap between actually what this big process finds out and finally what people get, and I think that's really amazing. And the third small comment I have, I'm here with my Brazilian student, Cynthia, from the University of Brasilia, and in Brazil, autonomy is not a topic. So what we here really take for granted as the central issue in this whole needs assessment, in Brazil, it's not autonomous. So older people are not expected to be autonomous, except if they are healthy and rich and things. But in general, there's no such a concept in everyday life. So I think it's interesting to look from different perspectives and question this taken for granted and autonomy. We look at other projects.
Thank you, Annette.
You need to resume.
Yes, I'm going to resume what Annette said for the online viewers. Annette made 3 comments regarding my presentation. The first one was telling me that she was proud of me. Thank you, Annette. The second one, and I'll respond to, Annette mentioned the idea of autonomy and the long assessment process and how complicated it is. And the reason why I didn't go into that in more detail is because I knew today there would be a lot of caregivers in the room. So I tried to focus the presentation in a balanced way that talked somewhat about loss of autonomy assessment and also what the caregivers told me, because everything they told me was so interesting. I had such a hard time sort of bringing it down to the nitty-gritty. And the third comment was regarding a contrast in Brazil, that autonomy isn't even taken into consideration. People aren't even expected to be autonomous. But for some reason, we expect all our aging people to be, oh, you have to be autonomous, even though you can hardly walk, but you still must be autonomous. And even though it's desired, it isn't necessarily the optimum state of being for all of the elderly. Any other questions? Sarita, Zelda?
Thank you very much, Norma, for a fantastic presentation and bringing all those three elements together. I think it really helped to help me to understand the expectations and how those expectations are influenced by what's going on in the system right now. But one of the underlying concepts that kept on coming back to my head a little bit was the concept of abandonment and this feeling of, the social workers not wanting to be abandoned by their institutions and their organizations, but also that the caregivers don't want to be abandoned by the social workers and the clients, as we call them, but are not also the sense of abandonment, not being abandoned by their families and not being abandoned by the system. And I think that's a really interesting concept that I'm sort of wrapping my head around, and the expectation of not being abandoned, like that you're going to help me take care of my loved ones. You're going to help me and you're going to support me as a social worker, that the institution is going to help them take care of the people that they're caring for. So I think it's it's making me reflect a little bit. So thank you for that.
So thank you, Zelda, for the comment. So for the online listeners, Zelda brought up the concept, the idea of abandonment, and how the expectations are actually, abandonment could be included with the idea of expectations. The social workers sometimes don't feel as supported as they would. They do feel somewhat abandoned by the system in their role, and they don't want to be, obviously. But the users, the clients, families, and caregivers do not want to be abandoned by the system. If they have need, they want their needs to be responded to. That's the way our system is set up. You're getting a worker in, and you will get the services you need. Unfortunately, that's not always the case anymore, and mostly due to budget, but perhaps things will change. Thank you, Zelda. And Sarita, you had a...
Well, a little bit of your comment about the clientization of caregivers when they have a problem versus clientization of a caregiver for prevention purposes. What is the place we give to intervention versus curative? And, and we say, prevention can save you a lot of trouble. And then it wouldn't be a negative spin on being a client. I wouldn't want to be a client in prevention and doing something that's proactive.
Absolutely.
And then we need to relook at things, and then you could be a much shorter term intervention rather than waiting until somebody is completely broken down and has a problem and making it longer. So that is something that needs to be, put forward. And the recognition, we did this at one point, we had it here, we had a caregiver center.
Yep.
That did just that. And unfortunately, the resources always go to curative versus prevention, but we need to look at prevention and we need to get it recognized as a valid and valued intervention, for caregivers.
Absolutely. And to summarize what Sarita brought up is the idea of prevention in terms of the clientization process. And that was the thing I found so interesting, because some of the studies actually say that the assessment process with a long form actually increases the clientization, the option of clientization. And Sarita brought up something that's near and dear to me is the idea of prevention. If we did more measures toward preventing the burnout and the health promotion of the caregivers, they shouldn't have to turn into clients to get the care they need or be abandoned by the system. And that could be something introduced into the process as well for the future, optimistic for the future. Any other questions? Are we okay for time?
Questions? We have just a few minutes left.
What, maybe one more if there is one? Pardon me? No questions from the internet?
I'm just wondering, though, maybe if something could be done now that you did this incredible government who's, and to try to sensitize them to the situation, because this isn't, in some ways, it's not a new thing. Because originally when I was in social work working in children's services, I remember before retiring telling my managers that it's not an assembly line. It didn't work for General Motors, and it doesn't work when we're working for vulnerable clients, traumatized populations. And now in medicine, even, they're trying to say, referring people to go to museums as prevention if we focus more, but at the same time we can't abandon the needs of when people actually do need it. So we have to work to help them understand the realities to make a positive change and not burn out everyone.
Right. The idea of prevention was brought up again by one of the listeners. Absolutely, and if more prevention was done, as she said, it would prevent the burnout. And I have to highlight, this is where social workers, and in fact all the home care workers, run up into a dilemma because of the time constraints and the productivity norms, and you have a certain number of hours, you have to do X number of visits per week, and the caregiver is not your client. You have to focus on your primary client, who is the person in loss of autonomy. So they have to sort of steal moments to pay attention to the caregiver, because they can't stat it. That came out loud and clear. The intervention with the caregiver is not always statable unless the caregiver becomes a client, and then a dossier is open, and that's the whole system is all in contributing to this sort of clientization process, which is unfortunate. Yes, Esther?
I noticed that you do not differentiate between caregivers for spouses and caregivers for parents. So I think there's a tremendous difference.
Yes, I absolutely agree. The question was regarding the fact that I didn't differentiate between spousal caregivers and, for example, adult children caregivers. And there is a big difference. Most of the quotes I gave were from the spousal caregivers, although I did have the other type. In fact, I even had caregivers who weren't spouses or children, but were parents that I interviewed. The reason why I didn't differentiate in this presentation is because there are some common issues that transcend whether you're a caregiver to a spouse or caregiver. In terms of the assessment, you're treated the same. And the children of the elderly people get burnt out almost as often as the spouses. What I didn't say, though, was that the spouses tend to have more of what I called the merging of identities. And when they spoke about the social worker, they more often used a plural pronoun. For example, it's our social worker, our assessment, and our intervention. There's more of a merging of identities, in fact, so it became more of a feeling of abandonment for them when they realized that they're not actually part of it. It was really the assessment. And many social workers have to really clear that up right away, that the client is that person and it's not you. But did I answer your question?
Well, no, I was just really good, and I also was thinking that the needs of the spouses are very different from the needs of the children. You're talking about expectations. I'm thinking more in terms of needs.
The needs of the spouses and the needs of the children. The spouses wanted respite as much as the children wanted respite. There's no doubt about that. The respite is one of the biggest needs that came up all the time. But absolutely, the merging of identities, that was more clear in the spouses. But in my analysis, I tended to group all the caregivers together rather than break them down into whether they were a spouse or whether a child.
Well, one of the things I just want to comment on is that at minorities, for example, I noticed that the spouses come almost every day, the children do.
Right. The final comment I'm going to make for the online people is that in terms of a long-term care institution, the spouses visit almost every day, but the children don't, for probably many reasons too. And I agree with you. I can't comment or disagree with you absolutely, you know, for sure.
I think we have to stop here. Thank you.
Thank you.